surgeon from Rajkot, Gujarat. He has been several times invited as a faculty to take lectures on various topics of ENT by IMA Saurashtra, at Saurashtra and Kutch. He was a past president of IMA and AOI Rajkot chapter. He is the organizing secretary of 37th annual conference of AOI GSB, and he is the organizing secretary of GMACON 2016. I hand over session to both the chairpersons.
Thank you for a nice introduction. Dr. Seemab, everybody knows him, no clear introduction needed for him actually. He's a wonderful surgeon and wonderful human being. Dr. Seemab is a known name in the field of OSA in this country. He is the founder president of Indian Sleep Surgery Association of India. He is primarily responsible for the spread of awareness and treatment of OSA in ENT fraternity of India. He took keen interest in the field since 2007. He was elected as the founder president of Indian Association of Sleep Surgery. Then he is now high-level talk with the central ministry to try and get rules and regulation for pre-employment checkup for OSA. It's great. And it was Dr. Seemab Shaikh who has spearheaded in the nation to get OSA and his surgical treatment covered via the insurance companies also. He is the main responsible for the concept of dynamic MRI in evaluation of OSA, and this concept has been accepted by many of the Western groups in their protocol of evaluation of OSA patient. He is that person, HOD of ENT at Indore Hospital, Pune, consultant sleep specialist attached to the KEMH Pune. He is a keen academician and enthusiastic teacher and travel all across the world in pursuit of his busy schedule learning and teaching experiences. He has formed a team with the people in Germany and USA and Far East for the propagation and the development of the science of sleep apnea surgery and treatment of snoring. Welcome, Dr. Seemab.
Thank you, Anand. Thank you very much. Thank you for being part of that team also, and you're very well into OSA now with all of us. Okay, good afternoon everybody. Now I am going to be talking about something which is a passion for me, and this talk of mine has been a bit repeat for the past 4 or 5 invitations that I've been getting across the country. I've been repeating this talk, and I thought it duly better for me to repeat it here also, because since we started off and since I started off about 10 years back into this field, and we got OSA getting organized into the country, with every year controversies kept coming in, and I thought it was best now that I probably handle a bit of these controversies on a very honest one-to-one basis and take this further. So this is going to be a very honest and candid talk from my side. All my friends who've probably seen this on my webcast or have been attending this, please bear with me. You probably know this talk of mine, but this is for the rest of those who have probably not got the controversies rest in peace. So if you speak to any of the previous seniors or the people 3 decades before, and they were doing snoring kind of surgeries, this is the universal treatment that was being offered to all of them. And whenever this treatment was offered, all of them, the patients were very happy, and so were the surgeons. Everybody felt that, oh wonderful, you know, we did this surgery, the snoring's gone, the patient is very fine. Now this happened until such time as there were a few people who came up and gave guidelines with regards to success of OSA surgery. In like Share and everybody, they came up, and then the AHI index came up, and there's so many other things that came up where they said that if you don't have this much AHI and this much improvement, then probably your surgery is not being successful. So that's where I think we as ENT surgeons were dictated by a bunch of physicians who were telling us that our surgeries were not successful. And that's why I thought, you know, we need to probably get this a little bit changed. So the biggest controversy lies in goal of treatment. So what are we talking about? You know, if you are treating OSA, these are our targets. We want to get them to be cured, significantly improve, or fairly improve, or then obviously be failures. And when the patient comes to me, they're coming to me in this area of what they have. They would be having quite a lot of issues which would be in this area, and when I probably treat them, this is where they would land up. So if you go by this kind of targeting that we've had, I would say the patient has considerably improved in the things that he came to me for. He may have come for his daytime somnolence, he may have come for snoring, he may have come for other hypertension issues, and I've seemed to have cured a lot of them or given good improvement to a lot of them, but I am not falling in that criteria where the RDI is or the AHI is coming into the picture. So do I really call these as failures? No. That's where we have to now understand that you cannot catch hold of just the AHI figures to try and give what is the so-called cure, because there is no such thing as cure. The entire treatment protocol is now changing towards quality of life improvement of that patient that has come to you, so that you can give him a better quality of life, just as we do in situations with allergic rhinitis, asthma, diabetes, hypertension. So this has got to change. And two of my friends across the world, all of us on the international circuit know them, Kenny and Brian, they've come out with this sleep goal criteria, which is available for you on the net, which is hopefully going to get presented very soon and accepted also, because this deals with not just AHI as an index, it also deals with issues of blood pressure, it deals with issue of the sleepiness scale, it deals with issue of your weight, everything. It takes into picture everything and not just AHI. So this, I think, would probably be one of the best criteria to try and get our OSA surgeries to be considered a success or not. And I really, really agree with them when they put out these statements. They say that, you know, we do realize that it's not simple to get into a sleep goal kind of a criteria where so many criteria need to be brought in. But at the same time, we definitely don't feel that AHI is the end-all and be-all of OSA surgery. So you need to start this kind of a conversation and get to understanding the treatment goals, and that itself becomes a big controversy. The other controversies that we are facing all this while is obviously now the BMI. The AHI no longer now defines our limitations, because even if you have an AHI of, say, 100, there is no problem in going ahead and operating that patient. BMI, we were not operating for reasons of comorbidities, for reasons where the patient may not be surgically very fit to be operated on, or where post-op criteria or post-op care would be very difficult. So you weigh the pros and cons. We still do that, but you do not keep a cutoff in the sense that if the patient has a realistic expectation of what you're going to achieve by doing that particular surgery in that particular BMI patient, then there is no harm in going ahead, because bariatric surgeries are done for people at BMIs worth 40. So if they are surgically stable to be done and they are willing to understand what you're getting done and for what expectations, then there is no harm in that. That should lay the AHI BMI controversy also to rest. We have a lot of issues with the diagnosing, and we all know that from our clinical examinations. We also know it all from the scopes that we use and the imaging. Clinically, we were arguing a lot about Friedman and Malampati. We both know, we all know that both of them now have their own space, have their own requirement. Malampati from the anesthesia point of view, Friedman from the clinical point of view, where we would be trying to evaluate the tongue-based positioning and then decide on the clinical results. Similarly, that's what happens with site of obstruction. You want to try and identify the site of obstruction. You've got DICE, you've got FNLPs. I'm not playing the video, it's a simple DICE video with a flexible endoscopy. And you identify where the level of obstructions are. Now, there is no controversy per se, but for everybody where DICE is probably not possible, you cannot directly just rule out the use of a flexible scope. So, if you're not going to go in for a DICE, also know that an FNLP in a lying down position in your OPD, if you have access to it, will give you a relatively good idea of the intrinsic diameter or the intrinsic airway, and the MRI, if at all you do it later on, will give you an extrinsic view. So don't write off the awake FNLP. DICE was being again argued upon because it was unphysiological, because we were using propofol, little extra, and the whole plane of anesthesia and the whole tone of the muscle changes. But with the availability of Dexmed and the availability of using intra-procedural polysomnographies, things have changed. But at the same time, they will continue to have limitations. So this is how we are getting more accurate with the DICE. You do a polysomnography on one side, you are doing your airway evaluation, the other side is showing you the level of the sleep that's happening, and that's how you can probably try and figure out at what level of sleep were you able to do that particular obstruction evaluation. Now, only the word of caution, which I think I will probably also take up somewhere in our medico-legal panel that we're doing in the next post-lunch session, is that you have to do your dice as a separate procedure from your surgical procedures that you've planned, because in a court of law today, you cannot say that I did a dice to the patient and then I went ahead and straight away operated on the patient because we had prior consent. There is no such thing as prior consent. The patient has to, in their own understanding, in their own sensibility, in their own awake situation, have been told about the results of the diagnosis that you've made, of the evaluation that you've made, and they must be explained everything, and they should have given you the consent, not the relative. So you cannot post a patient for an 8 a.m. surgery and say, I'll do a dice before the surgery and then I'll go ahead and do my surgery after that. That's not to be done. The other things that we were facing with dice as a controversy, we were not able to evaluate exactly at what level we were analyzing it. We had the vertical level, we had the collapse level, but the third analysis what we now need is to try and filter in or figure in an anteroposterior lateral or a concentric collapse. So this is like the oncosurgeons do. This becomes like a TNM classification now, where you are then able to be a bit more specific about what you are actually seeing when you're documenting the dice, because eventually it is nothing but an subjective study. Something that I may interpret may be different from what you may interpret, so you need to get more specific with the dice. So when you talk about, say, a V2C, O2L, T2, E2AP, you're getting a little more specific about exactly what you're seeing at those levels of collapses, whether it's anteroposterior lateral or is it a complete concentric collapse. The cine MRIs I have spoken about a lot. What I'm getting into is CBCT volumetric imagings now. It's a little too early to really discuss or decide what happens, but pre and post volumetric assessments with an MRI or a CBCT would probably help us document our results even better. And let's see what happens over a period of time. But for right now, cine MRI remains a non-invasive or a non-interventional method of trying to figure out exactly what is your site of obstruction, exactly how much is the obstruction there, and how much is the diameters in the mediolateral and AP lateral diameters. And that's why you need to use this. And cephalometry you do not rule out, because cephalometry still, for any work that you do on the bony cage, cephalometry would still remain the major test that you need to do, because that will give you the bony diameters that you want to handle and not just the soft tissue ones alone. So we have eventually, after all the controversies, come to an evaluation consensus somewhere where we recommend that you definitely do a level 1 study, but mandatory that you do not do anything without a level 3 study. Now this is, I'm presuming that all of us know the levels. It's beyond the gamut of this particular talk to get into those levels. But minimum level 3, if possible, do a level 1. And similarly, for the site of obstruction, do a DICE, or you do an AFEC FNLP in the lying down position and correlate that with a dynamic MRI. So either of these, and if you can possibly all of them, then it gives you a much better correlation as to what is happening. Nasopharynx, nose and palate surgeries that were there, the only controversy that always used to be discussed in all OSA workshops was whether you want to do the nose and the palate in one sitting, nose, nasopharynx or palate in one sitting. So I think a lot of consensus has come on that. It's all depending on the fact whether you're going to really be packing the nose or the kind of procedure that you're going to do in the nose, nasopharynx. 2 majors, 1 minor, 1 major, 2 minors. These are the kind of things that you can possibly do, but provided you do not try and pack the nose. So if you're going to pack the nose, then don't try to do too much there in the palate or in the hypopharynx region, because that's going to create problems post-operatively for the patient. So this is something that you need to keep in mind. And the other biggest controversy was the palate. It still remains quite a bit of a controversy, but certain consensus are very clear on that also. The excisional work is out. We are no longer talking about excisional work. We are talking about reconstructing the palate. We are talking about reconstructing the sling mechanism that deals with the palate causing the obstruction. So everything that you do, whichever kind of pharyngoplasty that you're trying to do, whether it's a reconstruction pharyngoplasty, relocation pharyngoplasty, excision pharyngoplasty, whatever we are doing, you're basically dealing with relocating the palatopharyngeus muscle somewhere on the lateral side, somewhere on the superior lateral side, so that you have an AP and anteroposterior as well as mediolateral improvement in diameter. And that's where the importance lies with the selection, not just of the palate. It also lies with selection of the patient as a whole, whether the motivational factors are there, whether there are issues related to alcoholism, whether there are issues related to accepting what you're going to do with those minimally invasive procedures on the palate. And by minimally invasive, I am still classifying those that handle the palatopharynges as still relatively minor, because we all can very easily do procedures on the palate. Any JR, any SR, any freshly passed out person can handle the palate. It's not such a big deal. But you will have issues when you're dealing with a very, very bulky palate, and that's where even excisional sometimes does not help. So that's something that we will need to keep in mind. This is the new fad, and like every one of us, when something new comes up, we all want to put our hands into it. We want to keep trying, we want to keep presenting. It was started initially by Professor Vicini, but he also himself is giving a lot of second thoughts to this, because there are lots of procedures that have come up as a subdivision of the Bach pharyngoplasty, whereby all that you are basically attempting to do is pick up the palatopharynges, which you will see once the tonsillectomy is done, and you are hooking that onto the pterygomedial mandibular raphe on your lateral side. So that's probably the strongest thing that you have to hook on that palatopharyngeus muscle. So whichever way you want to hook onto it, there are additionals. There is the Alianza technique now that has come up. There are people that have come up in Italian group itself that are doing this differently. But the fact of the matter remains that you are trying to pull it and push it onto the side. Now the sample sizes are very small as yet, because each one who's dwelling into it wants to try to put his own 2 paisa and say, oh, I'm doing it differently like this, and I'm doing something differently like this. The problem in OSA remains is how much can you do everything differently? How much difference can you do to something that is there which is limited to that area that you're working in? So when everybody tries to do some things differently, we are definitely not going to get those huge sample sizes as yet. So please hold on your horses before you try to start placing a particular surgery in a bracket with these are the results and that are the results. The base of tongue, high and low, is what decides what you're going to do. So it's very obvious that if you have a high base of tongue, you will have to approach it intraorally some way, whichever way you want to do it. You want to do a laser excision, you want to do a coblation excision, you want to do a cautery excision. But if you're dealing with something in the low tongue base, then you probably have to go externally with a hyoid suspension or an RF, or a hyoid added on with an RF based tongue. So these are some things that now the controversies are very clear. We discussed a lot about base tongue, and it has come to this kind of a consensus that if it's a high base tongue, you have to decide that which of the procedures that you're going to do, and those procedures would not be your decision alone, but they would be depending on the patient profile, the kind of facilities and the backup that you have, the kind of your own training skills, because this is something which you should introspect and think before you really get into it. Not that OSA surgery is highly skillful or there's an extreme amount of skill that's required. Extreme amount of wisdom is required in OSA surgery, not skills, I would say. PAP versus surgery was one of the biggest controversies that I've been facing on all the chest forums that you get invited on, and now it is really very clear, because even the chest physicians do acknowledge that their long-term compliances are as low as 40 to 50% with CPAP. So that is literally, it is the same like saying CO2 laser versus radiotherapy. We've got an even balance out there, and there is no harm in us if we get a good surgical candidate for us to be the primary people dealing with OSA, because even if 3-4 years down the road there is a failure or there is a decrement in the success rate, it still matches what the CPAP failures are all about. So we are definitely more important in dealing with OSA as surgeons. Now we all do pediatric OSA, so I won't get into that with coblation, but my only question in pediatric OSA comes is, okay, you've seen a patient, you've seen the x-rays, they've come to you with some mouth drooling or maybe mouth opening and snoring and stuff like that, but otherwise the patient is non-comorbid, and most of the times eventually there is a little bit time that goes in treating their allergies, where you probably land up using Montelukast or something for a month, and the patient improves, or the parents feel that the patient is improved. Now you have a patient diagnosed OSA, you know that this guy is going to benefit with surgery, you also know as he's improved and the parents are not really very keen on it, and you also know that the patient is non-comorbid. So does it really make sense to go ahead and operate such patients? This is a study that was brought out. It is something that you can pick it up on the net. This is the very good meta-analysis of the entire situation that I spoke about, and they said that if you want to prevent the neurocognitive issues in a child, then the earlier you operate is always the better. And today's date, we have equipment whereby and safety measures, so the earlier you operate in a pediatric OSA, it is always better. Lay that controversy to rest. No controversies in all this epiglottis. I'm going from top to bottom, so I'm trying to remove as many controversies as I can. There's hardly any controversy in removing the epiglottis. There's this which is not to be done, that's why I put this up. UP3 was done on a highly comorbid patient, and I was called in to do a tracheostomy for this patient because they couldn't wean him off the thing. This is absolutely not to be done. The other biggest controversy, do you want to do everything in one stage or do you want to stage out the particular procedure? Now the choice of this would eventually depend on not us alone. A lot of issues. In the days of medical tourism, initially I was a very big proponent of single level multi-stage surgery, but with medical tourism coming in, you have patients who come for maybe 8 or 10 days to you, and you cannot sit and keep calling them 10 times from there. So you've got to tailor make your decisions between single level multi-stage or single stage multi-level kind of surgery, and that would depend a lot on where the patient is coming from, what is his motivation, what's his socio-economic status, what is the kind of collapse that you're finding, are you really, confident enough that this particular single stage surgery is going to do a lot of wonders for this particular patient, except for MMA. And your own factors will come into, but eventually the risk to benefit ratio of the patient is what will decide whether you will discuss with the patient a single level or a multi-level surgery in the same setting. So very important to keep that risk to benefit ratio of the patient, not you. And you will also realize as you deal more and more with OSA patients that the changing trend is mostly towards going as non-invasive as you can, because that's what even the patients really want. About hypoglossal stimulators, so much has been said. So much has been said over the years. 10 years back when, I started off, we used to say this is the future of OSA surgery, and surgeries were performed in Australia, in Canada, in many places. The FDA approvals were got, results were kind of shown, but there was such limited samples that results really didn't matter. Now 10 years later, even now my future in India slide still remains hypoglossal stimulators. So 10 years back I used to say future of OSA, hypoglossal stimulators. 10 years later I'm still saying hypoglossal stimulators future. So I really don't know whether in my lifespan or in the next 2 decades whether this will really happen. But it is something that we have to keep in mind. So I will like to be very brief, and I will end in the next few slides only, where I'm now telling you that definitely AHI normalization is not our goal, and your end point should be a safe and a happy patient, and of course their bed partners. You've got to factor in a lot of things except partial improvement where it's there. Make sure that the failures are tackled in well. Obviously the counseling part we'll tackle in the MLC situations where realistic expectations have to be given. And in the next few slides I may ruffle a few feathers, but it's purely unintentional, so please think aloud when I'm talking about this, when I'm saying this, that when I do this, now that I'm doing, why am I doing this? Am I doing this just so that I can come up on the dais here and make a presentation and say, oh, I'm doing something different? Am I doing this because I can take this presentation to a chess forum and say to them that, listen, you guys told me that I didn't know where is the level of obstruction at what stage, and now I'm doing a PSG, so I'm getting the level of obstruction at that particular stage. Is that why I'm really doing it? Because if I'm not able to understand the pathophysiology of OSA at a very, very deeper level, then all this exercise becomes pretty futile. And unless and until you really know that something that you are doing has to translate into better surgical results, then most of your exercises trying to do something different would probably not be that helpful in the long run. So what I'm trying to get at is that maybe we need to do a little bit of thinking out of the box. Maybe we need to do a little bit of lateral thinking. All this while in the past 7-8 years, we've been directing our efforts to the base tongue, the genioglossus muscle, to the palatopharyngeus muscle. We are doing everything eventually which concentrates down to these muscles. But maybe we need to be thinking more like the nerve stimulators, or maybe we need to be thinking like brainstem stimulation somewhere to try and get this thing happening. So we need to be on the same operating protocol when we are doing OSA surgery, because we have to understand that we as ENT surgeons need to be tackling only the obstruction, and we cannot do a lot of other things for the rest of the reasons for the sleep apnea or the obstruction, which are not related to mechanical obstruction. So this is something which is personal for you. Whether you really let go of the patient of SN loss to an audiologist and say I have nothing to do with you, or whether you want to really go further and treat them completely. So my main thought would always remain, and the reason to getting this organization and getting people to be organized would be that you cannot ever change the patient variables. Patients will be different every now and then. But at least if we are on the same page and remove the surgeon variables with guidelines, with training, with fellowships and with a proper approach. So if the surgeon variables come out, then you know that the patient will be treated the same in Delhi, Bombay, Pune, Chennai, Bangalore, anywhere. There will be the same operating protocol for that particular patient. So in the end, I leave you with a small little 20-second clipping which gives my philosophy of life towards this entire process of OSA, and this says it all. So I just hope the audio works now. Do we have the audio working?
मुझसे बेहतर कहने वाले, तुमसे बेहतर सुनने वाले, कल कोई मुझको याद करे, क्यों कोई मुझको याद करे, मसरूफ ज़माना मेरे लिए क्यों वक्त अपना बर्बाद करे, मैं पल दो पल का शायर हूँ.
Thank you very much, because this is pal do pal ka thing in this suffer of this OSA, and tomorrow there will be others, there will be better people than you listening, better people than me talking, but the journey will have to continue. Thank you.
Thank you, Dr. Seemab. It's a wonderful presentation.
Thank you.
If there is any question from audience?
Questions would be related to
one
lunch.
question from myself.
Yes.
Are there any benefits of doing the polysomnography while doing the OSA? And don't you think the duration of the polysomnography is very short when you're doing the DSA for any kind of interpretation?
Yes, absolutely, you're right on that front, but that if you see in a complete picture, the problem with OSA will always remain that every evaluatory effort that we take, whether it is to evaluate the level of obstruction or whether it is to evaluate the physiological part of it, will always have a short window. Even when you do a DICE, you can't do it for more than 15-20 minutes, that's not confirmatory. Even when you do a polysomnography intra-procedurally, there's going to be a limitation. Even when you do a dynamic MRI, there's going to be a limitation. So this is a limitation that you're going to have to factor in, because even if you do a complete polysomnography, how you slept on Monday is not necessarily the same as you sleep on Tuesday, on Wednesday or Thursday. Which does not mean that you can continually keep on doing these evaluatory procedures. We tend to take a random one snapshot of either your sleep patterns or your obstructal level patterns, and then you work on that as a baseline. Because this is an argument that's always going to remain. You are going to say, now the best thing would be to do a dynamic MRI night long along with a intra-dynamic MRI PSG, but that's not logistically possible. So how are you going to get over these hurdles? It's not possible in OSA to get over these hurdles.
And one more thing, sir. If AHI is no more the criteria, how do we conclude the surgical results? First thing. And the second thing is, can we have a situation where the snoring is gone and the AHI is abnormal?
And the AHI is
abnormal.
Yeah. So that situation is very much possible to answer that second part, because it's like we always say that the snoring is just a symptom of your disease. Removing the snoring does not mean that the OSA is gone. To answer your first part, the AHI still remains the criteria because it is documented and it is known. We have yet to document this criteria, and you have to yet get it published and approved. You understand? So unless we take the efforts, right now for all practical purposes on the international field, they are only talking about AHI as a criteria. But who are these people who are talking? They are not necessarily the surgical community. It is the non-surgical community that is talking. So unless the surgical community takes that effort to prove to them and show them that, listen, AHI is not necessarily the only criteria, so many other things have improved, and right now what we are doing is the quality of life quotient improvement. If that happens, and if you downgrade your OSA to a certain level where the patient's quality of life becomes better, then that's as good. Because like I keep saying it all the times, do you cure asthma? Do you cure diabetes? Do you cure allergic rhinitis? You bring it under control so that the patient has a good quality of life and can live normally. And that's what you've got to aim for in severe OSA cases.
Thank you, sir. Thank you.
One question, Seemab. Do you routinely do regular sleep endoscopy for pediatric group?
No, regularly not at all. Pediatric sleep endoscopies I keep reserved for failures of cases post TNA already done.
Okay.
So that's when I would like to find out why that particular patient has failed the TNA surgery that was advised.
Okay. Then what about CPAP trial before and post-op?
Definitely I do the CPAP trials in the first stage. Even pre-op I do those trials much before we take them up for surgery.
Okay.
That is something which is documented, put down in writing, and you also can assess how much of an improvement. Let's say you have a patient with primary complaint is EDS.
Okay.
Right, of somnolence, and if you give a CPAP, you will have a better idea how much of reversal of the EDS will happen. So that way you will have a better judgment about how aggressive you want to get onto this patient.
Okay. How long you advise to go for a CPAP trial
No,
pre-operatively?
I don't give them a time limit. I tell them please go ahead and use it as long as you can till you think that you are either comfortable or not comfortable with it. So
Okay.
give yourself a time frame of your own. Don't write it off too early in 3 days, 7 days, 10 days. Take even a month if you want to.
No. Do you advise any CPAP trial after the surgery?
Immediate post-op, not really, unless it's really needed at the, patient has a really high BMI and you've been using it for a very long time before that. I would rather recommend them to use it maybe 3-4 days after the surgery post-op period is over. The critical phase, once it's over, they can start using it.
No, in my experience, actually, immediate post-op surgery, the CPAP helps to reduce the edema,
Okay.
as well as I will ask them to use for at least a month, because already the CPAP user, I'll ask them to use for a month. Definitely, the results are better than non-CPAP user.
Now, I would agree with that, would depend on the surgery performed,
Okay.
but I would definitely agree with you on that.
Okay, thank you.
Hello? Sir, my question.
Yeah, sure.
So, Mediclaim right now,
Yeah.
just want to know okay, right now how much Mediclaim is helping us in sleep apnea.
Yeah, well, I'm actually working on that, but right now, let me tell you, all surgeries that are performed for OSA are totally passed under Mediclaim. You only don't write the word snoring and sleep apnea, you write obstruction to airway. So if you're dealing with nose, you say obstructed nasal airway because of so-and-so, difficulty in breathing through the mouth because of so-and-so, and then you go ahead and send them for sanction. And invariably, I have not had any problem sanctioning any of the surgeries, provided you just do not write sleep apnea, do not send a report of the sleep study along with your sanction letters. You can, at the most, your imaging studies and whatever else you need, you can document and send that.
DICE also.
Sorry?
DICE report also we not to
No,
send.
DICE also. DICE, you can just say that we are identifying the level of obstruction, why is having a problem in breathing. But we don't say that the DICE was done for detecting sleep apnea obstruction. We just say he was having a problem in breathing. We did a DICE to try and find out where his airway was being obstructed during sleep. That's all. Up till now, frankly, I've had no problems with getting it passed through Mediclaim. Done?
Thank you.
Thank you. And I request Dr. Seemab Shaikh and Dr. Dipesh to felicitate Dr. Anand and present memento to him.